Hey everyone, and welcome to this explainer. Today, we're going to unpack the really rigorous, step-by-step strategic playbook you absolutely need to build a digital therapeutic app. And not just build it, but actually survive the intense regulatory scrutiny and get it deployed in real healthcare settings. If you are looking to build something that fundamentally changes patient care, well, you are definitely in the right place.
Let's just face a pretty harsh truth right out of the gate here. When it comes to digital therapeutics, the code is literally the easy part. Writing the software? That's simple. Proving to the FDA that it actually works, integrating it into massive, complex hospital systems, and convincing payers to reimburse you for it, that is the real challenge. Anyone can build an app, but very few people can successfully engineer a true therapeutic intervention.
And we really have to draw a hard line here to understand the landscape. A digital therapeutic is not just a wellness app. It's not a meditation timer wrapped up in some clinical jargon. What we are talking about building today is software that is literally prescribed as a medical device to prevent, manage, or treat a specific disease. It's a whole different ballgame.
So, to navigate this brutal, multi-year build process, we're going to follow a 5-step builder's journey. Claims and pathways, protocol engine, architecture and EHR integration, clinical validation, and finally, market launch. Let's get right into it. Step 1. Medical claims and regulatory pathways. This is where we lay the groundwork.
Here is the absolute crucial point you have to understand. Agencies like the US FDA and Australia's TGA classify true DTX products as software as a medical device, or SAMD. The very second your software claims to treat a condition, say depression or insomnia or chronic pain, your regulatory pathway dictates literally everything else. It drives your engineering timeline, your funding needs, the whole shebang.
And listen, choosing the wrong pathway here, that's going to waste months, maybe even years. For example, the 510(k) pathway is the fastest route, but only if you can prove your software is substantially equivalent to a product that's already been cleared. But what if you're building something completely novel with no predicate device? Well, then you'll need the de novo pathway, which means you're building your clinical evidence completely from scratch.
All right, moving on to step 2, designing the clinical protocol engine.
Now that our regulatory path is locked in, we have to build the clinical brain of your app. Look at this. The Engage framework perfectly maps out the exact failure modes we absolutely have to avoid. If your clinical engine doesn't proactively adapt to the patient's context to fight off engagement killers, things like novelty decay or value-effort imbalance, well, your scientifically validated app is just going to become a deleted app. It happens all the time.
So we kind of have to rethink what engagement even means here. Your protocol engine has to use digital micro-engagements, the clicks, the logins, the notifications, as a causal bridge to drive macro engagement. And macro engagement means actual real-world behavior change. We're talking about a patient actually completing a physical therapy session or finally sticking to their medication routine.
To actually build that bridge reliably, your engine needs a highly deterministic architecture. We're not talking about a basic content management system here. Every single clinical decision your app makes, like adjusting a CBT module because a patient's PHQ-9 depression score changed, has to be processed sequentially. And more importantly, it must be fully auditable and traceable to keep the FDA happy.
Okay, step 3, technical architecture and EHR integration.
This is the technical plumbing that makes this whole system secure and scalable. You've got to draw a strict boundary right from day one. Literally, keep your protected health information, your PHI, locked down in a highly restricted vault. Then only push de-identified or pseudonymized data over into your analytics lake. Setting it up this way lets your data scientists move incredibly fast, while keeping hospital security officers perfectly comfortable.
Now, if you want doctors to actually prescribe and monitor your app, you've got to integrate seamlessly into the electronic health records they already use, like Epic or Cerner. You just can't ask a busy doctor to open a separate browser tab for your app. They won't do it. You achieve this using mandatory data exchange standards, mostly Smart on Fire for launching the app, and HL7v2 to handle those older legacy workflows.
But remember this, APIs are literally just the starting line. Getting the data to flow, that is only half the battle. You still have to navigate these grueling IT security reviews, figure out really complex patient identity matching, and bridge huge workflow gaps. Honestly, this is where a lot of great apps go to die.
Which brings us to step 4, clinical validation and evidence.
Because without rigorous clinical evidence, payer coverage is just a pipe dream.
You're going to have to progress through a pretty grueling sequence. This usually culminates in double-blind randomized controlled trials, RCTs, often testing your therapeutic against a fake or sham app just to definitively prove it is safe and effective. And keep in mind, you have to do all of this before you even submit your package to regulators.
Let's talk numbers. $1.2 million to $3.5 million. That is the realistic total investment you're looking at from your initial concept to a commercial launch. It really highlights that DTEX development is not for the faintly funded. You are paying for software development, highly rigorous clinical trials, and deep regulatory consulting, all at the exact same time.
And look at this timeline, 30 to 60 months. That's a minimum of 2.5 years. If anyone tells you they can get a fully cleared, prescribable digital therapeutic out the door in 6 months, they are completely ignoring the reality of clinical trials. You absolutely have to plan for a multi-year journey and manage your runway for the long haul.
All right, home stretch. Step 5, navigating the market launch.
You survived the trials, you got the clearance, now how do you get paid? Globally, this market is incredibly fragmented. Take Germany, for instance. They offer the DIGA fast-track pathway, which is amazing because it directly links regulatory approval to actual statutory health insurance reimbursement. But then you look at other systems, like South Korea, where you might get regulatory approval for the device, but you are left entirely on your own fighting for payer coverage.
To actually succeed commercially, especially in the US, your product has to slip effortlessly into a doctor's normal day. That means integrating with e-prescribing networks like SureScripts, securing proper identifiers like an NDC, giving clinicians dashboards that show real actionable outcomes, and maintaining continuous post-market surveillance so you can report back to the FDA.
So, as we wrap up this explainer, I want to leave you with this question to chew on. Are you just building a shiny new app, or are you truly ready to engineer a medical intervention? The barrier to entry here is unbelievably high. But if you respect the clinical, technical, and regulatory realities we've mapped out today, you genuinely have the potential to build software that actively heals people. Thanks for joining me, and keep building with purpose.